Hey everybody, welcome back to the ECG channel. My name is Reid, and don't forget that you can download the PDF for this ECG, this exact document, down in the description below so that you can follow along, make notes, keep it for your studies later on. So let's jump into it. So the first thing I like to do with ECGs is look at the forest, and the trees of the forest are my QRS complexes, and so really just try to get an idea of what I think is happening with this rhythm. So I may come down here to lead 2, and I see I've got a wide complex rhythm that appears to be regular. If I look through the entire strip, it's a very regular rhythm. And it's wide, right? If I look, my QRS does seem to be a little wide. If I look at the duration. And so I see that there might be some P waves before my QRS is kind of, I don't see one there. So maybe wondering what's going on, but it's a regular rhythm. So, just starting to think through maybe some of my differentials for a regular rhythm with some kind of weird P wave timing. If I find a QRS that lands here on a solid line, we can say the rate is 300, 150, 100, 75, 60, just under 60, so maybe 58 beats per minute. So we've got a little bit of a bradycardia, okay? And so we do say we have some P waves. Let's take a look at those P waves. Those P waves, if we look, are upright in lead 1, and they are upright in AVF. And so that tells me that if my sinus node is high in the right atria, depolarizing down and to the left, which will produce upright P waves in 1 and AVF. So these are P waves that are being produced by the sinus node. Okay. And now I think what the most important part of this ECG likely is going to be is to evaluate the PR interval, or really what I'm getting at is to evaluate the AV node, right? Because the next step in depolarization is going to be for the AV node to capture that signal from the SA node and send it down. And so we see here, right, that if I measured this PR interval and only this one, that would be normal. Excuse me. That would be a normal PR interval. But this PR interval is very different, right? That would not be a normal PR interval. And same thing here. This wouldn't either, but it's so different, right? The PR intervals seem to be changing every single beat. And so that makes me think, I wonder what the relationship is between my P's and my QRS, right? Because ideally there should be a relationship where a P that conducts to a QRS does so in a particular pattern. And so that makes me wonder, where are my P waves? Let's try to find them. I might use maybe V1 has good P waves typically because they're nice and sharp biphasic P waves. And so I see I've got a P wave here. Definitely got a P wave there. Let's see, I've got one here. I've got one here. But let's look a little closer. Look in the exact middle. And you see right on that ST segment a little bump. You see a little bump right there on the ST segment? That's an actual P wave that's hidden underneath the ST segment of that previous beat. And then if you look maybe right here, the end of that T wave has a little bit of a dip that we don't see in other QRS complexes in ST segment and T waves. So I would say that's another P wave that's hidden right there. And then similarly, look at the beginning of this QRS. Notice how the beginning of this QRS has a little bump to start, but that doesn't happen in the other ones. That's probably another hidden P wave. And so if you notice there's a trend of P waves marching through, here's another one hidden right there at the end of that QRS. And look, the P waves are just marching through, right? Look at this. T wave is a little bit more kind of peaked than the rest. It's probably because there's a P wave right there, right? You gotta start seeing through these things, guys. And so we have P waves marching through this beat, through this rhythm, and they are not occurring in any particular relationship to the QRSs. We have QRSs, I'll draw them in, say, red arrows, that are marching through at their own rate, irrespective of my P waves, right? And so I think this is a great diagram to see that there is no relationship, right? My P to P interval, if I measure my P to P intervals, I would say that my P to P rate, let me find a good one here, is going to be something like from this one, 300, 150, maybe 100. My P to P is at 100 beats per minute. In my R to R, we said my rate is 58 beats per minute is my R to R, right, or QRS to QRS. So there's no relationship there, right? And so I have P's that are marching through at a faster rate than my QRSs. So that tells me that I've got P waves being generated by my AV node at a roughly 100 beats per minute, right? And they're just depolarizing. And then there's an escape rhythm from somewhere in the ventricles that is having to do an escape rhythm through the ventricles at a rate of 58 beats per minute, right? And so that tells me that there is a block at my AV node that is completely inhibiting any P wave to get down to my QRS, and so this is a complete or third degree AV block. Okay? And because the rate of my escape rhythm is 58 beats per minute, I know that the junction just below the AV node, maybe right there, I know that the junction for junctional escape rhythms go at a rate of 40 to 60 beats per minute. So that's a junctional escape rhythm, but usually junctional escape rhythms are narrow, right? Usually they're narrow because they follow the rapidly conducting His-Purkinje system, right? But let's take a look at the morphology of this QRS. We said it was a wide complex QRS, so my QRS is greater than 120 milliseconds. Well, could we have a wide QRS in a junctional escape rhythm? Absolutely. We could have a bundle branch block in the setting of a junctional escape rhythm as well. And so look, we've got in lead 1 and in lead AVL, we've got these slurry, look at that. It's not returning back to baseline very well. All right, look over here at V5. We've got an R, and then we have an R prime. That tells me that there are late signals going into the left ventricle, right? That is very characteristic of a left bundle branch block morphology. Similarly, if you look at V1, we do not have a septal R wave, right? We have no septal R wave. And we know that the septum is depolarized by the left bundle. And so we know that the septal depolarization is typically represented by a septal R wave in V1 and V2, but we have lost that. It's very, very, very characteristic of left bundle branch blocks. And so I would say that this is a complete AV block with a junctional escape rhythm that is being conducted with a block of the left bundle as well. So we get good right bundle conduction and good RV depolarization, but then we have to go cell to cell later on, it takes forever to do this, to the lateral aspect of the left ventricle, which is why we capture in the lateral leads 1 and AVL, these kind of slurry upright forces. And in V5, V6, the same thing, slurry. It doesn't return back to baseline very well, and we lose our septal R wave. Okay, so now we've kind of done all of that. Let's look at our QT interval. Right, if I measure between an R to R here, you can see my QT ends by the midpoint. I'm happy about that, right? Next thing I'll do is I'll look for pathological Q waves. I don't see any, right? We've lost our septal R wave, but that's probably because of the left bundle branch block. Otherwise, no pathological Q waves. ST or T wave changes, you would use Scarbosa's criteria. Scarbosa criteria. Look that criteria up. That's what you use in the setting of a ventricular paced rhythm and a left bundle branch block rhythm to evaluate for infarction or ischemia. I don't see any issues there from a Scarbosa criteria standpoint. And then when we put this all together, what do we have? We've got a complete third degree AV block with an underlying sinus rate in rhythm at 100 beats per minute, but the escape rhythm is at 58 beats per minute. Our escape beats have a morphology of a left bundle branch block, so I'm going to say this is the junctional escape based off of my rate, knowing that my junction goes at a rate of 40 to 60 beats per minute typically for escape rhythms. So I would say that this is a complete AV block with a left bundle branch block escape pattern. So I hope this helps. If you have any questions, put them down in the comments, and if not, see you on the next ECG video. Thank you so much for watching. Think about liking this video and subscribing to the channel if you enjoy this content, and we will see you on the next ECG video. Take care.